there was pre-reading sent by Lauren. I'm not sure how many of you went through it, but clinical governance has been asked before in an exam, and it basically encompasses everything we do, everything we are supposed to do, everything that we are held accountable to do. And there's various definitions. These are a few. It's basically the framework of what we do to ensure quality service. It's also the same framework that our seniors, our line managers hold us accountable to. But I think this is a definition we need to understand. And if you look at the various aspects thereof, or the various pillars of clinical governance, you'll get different images and different, depending on which country or which governance committee you read up on. But these are the basic pillars of clinical governance. There's risk management, information management, human resources, and so on and so on. And each of these pillars have subheadings, and that's what we want to quickly talk about. Clinical effectiveness is basically your service delivery, policies, guidelines, communication, collaboration between units, etc., etc. Evidence-based medicine, how do you ensure that you practice evidence-based medicine? Clinical audit is to do with improvement. Audits, we can even add research over here, but it's to do with improvement. Risk management, patient safety goes together. That's the system where you ensure that you provide a safe service and monitor on, etc., etc. Openness is where you're transparent with your service, patient and community involvement, patient feedback. We talk about patient-centered care, but how much of our care is actually patient-centered? But that's where that comes in. And if you look very closely at your REG program, and not only our REG program, but REG programs in general, that's probably what we are trained for. We spend 4 years on driving clinical policies, and then once you're qualified, you're expected to be a consultant and manage all of these things. So I think it's important for us to understand, get an idea of it, and expose ourselves to it as much as possible. This is a different graphic about the clinical governance. This one has the research and development. If you look at the bottom, these ones only have 6 pillars with research and development at the bottom. And if you take all of those pillars and you will be able to subdivide it into different working clusters, like for example, patient safety, M&Ms, by clinical effectiveness, policies and protocols for each department, shop for presence, etc., etc. So for each pillar, you will have a set of subheadings that you have to cover. So on the other hand, you get corporate governance, which is a little bit different. This is the most basic, most simple definition I could find. I don't want you to remember it, but basically clinical governance is about the patient. Corporate governance is about the facility. If we can understand that, clinical governance, ensuring quality patient care, safe patient care, etc., etc. Corporate is more about the facility, the processes and all those things. Corporate governance includes stuff like your finance, your budget, human resources also on this side, maintenance, asset management, procurement, managing of all the contracts. It's how to manage the business part of it. Clinical governance is how to manage the clinical part of it. That's basically essentially it. And I've mentioned corporate governance here because we can't distance ourselves from it. We traditionally, we're only involved with the clinical governance, but the more and more you are intertwined in wherever you work, private or public, or be dealing with corporate governance as well. So it's important to know, we can't neglect this as well. That's basically what I want you to remember. In summary, governance is very broadly defined as clinical, corporate governance. Each one has their own pillars and their own subheadings. You should know a little bit of each, and we will play around with this in our session as well. That's my first 5-minute session. I'm going to go on to the next one. We can ask questions at the end. So my next one, my second part, is about quality. What is quality? The WHO defined as a long definition It's about the extent to which healthcare services provided to the individuals, blah, 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 safe and effective and all those things. If you summarize it, it basically means the right care to the right patient at the right time, at the right cost, etc., etc. Or if you simplify it even more, it's care that you are proud of and that you would like your family, you would proudly bring your family to that health facility. It's something to do with that. It's sometimes difficult to define. And the WHO describes 6 dimensions of quality, another list of things to remember. And the first one is quality healthcare needs to be safe. So you need to deliver healthcare that minimizes risk, patient safety, risk management, and it includes preventing and reducing medical error. It has to be effective, and this is where evidence-based protocols and guidelines comes in. It has to be timely. So this is quite important. If you ask a specialist what does he think quality care is, and if you ask a patient what does he think or she thinks what quality care is, you will get 2 different answers. A patient, and this is evidence-based, if you ask a patient what do you think is quality care, it means very short waiting times, no pain, and good communication. Those 3 things, and those 3 are probably the ones that we are the worst at. So it also depends on who you ask. If you ask policymakers and what quality care is, they will talk more to budget and so on. So it all depends. Quality needs to be efficient. So minimize waste, and we'll talk about waste a little bit later on. If you provide quality care, but you spend the budget and you run out of budget, that's not quality at the end of the day. It has to be equitable. It has to be the same across all patient types and so on. And what is very important with equitable is, for the equitable thing, we have to ensure access to everyone, not only those that can get to the hospital. So it opens up another box as well. And then it has to be people-centered. These are the dimensions of quality, and this will definitely be in one of the groups a little bit later on. I want to speak about the difference between quality control, quality assurance, and continuous quality improvement. Quality control is basically a process that evaluates some system, pick up a mistake and fixes it. For example, I want everybody to be triaged, every single patient to be triaged. If they're not triaged, we address it and we can move on. That's quality control. So the question would be, the goal is everybody needs to be triaged, if not triaged. It's usually a binary thing, but that's quality control. Quality assurance is more of a system that monitors all the quality control aspects. So if you have quality control in triage, you've got quality control with providing medication, IVI medication, and so on. Quality assurance is the system that governs it. It's the system that coordinates it. And when we move one step further to continuous quality improvement, we are talking about a system where we have clear targets, measurable targets, tangible targets that we work towards. For example, we want the triage accuracy to be 100%. At the moment it is 50%. And now we try and understand why, and we work our way continuously towards the 100%. That's continuous quality improvement. So it's the next step. We identify things, we monitor, we find out where we are at the moment. We find out what we should be doing, our targets, short-term targets, long-term targets, and we work our way slowly towards PDSA. That's the difference between the 3. If I go in a little bit more detail, quality control ensures that the processes remain stable. It ensures that the performance remain between the upper and lower control, and it focuses on the process on the ground. It's usually managed by the people on the ground. assurance is to verify that quality control, all the different quality control processes being maintained. This is often a committee and it monitors processes. So this is at a higher level. And then these are the differences. I think it's important to understand where quality assurance control fits in and how it is different to continuous quality improvement. Continuous quality improvement is we decide on what is important, we set targets, we measure where we are, and we try and work our way there. So let's talk about continuous quality improvement. It's basically a philosophy that says, I want to improve all the time. That's it, all the time. And I think it's something that we need to strive for. When you see a patient, how can I do better the next time? If you triage someone, how can I do it quicker, faster, more accurate? How can I decrease the cost? It's something we need to ask ourselves all the time. Basically asking, how can we be more lean and how can we decrease waste? And that's what we mean by that. So if we look at continuous quality improvement, as you would have heard, I've said before, you can't have CQI without targets, without goals. You can't have CQI if you're not monitoring events. And for you to, sometimes you need to decide what you will monitor. And that usually depends on what your facility wants you to monitor, or what your faculty or your province. Sometimes there's set goals. These are the quality indicators. Sometimes you have the capacity to do more than what is expected. For example, if your data management systems are better, you can monitor more and so on. So for each quality pillar, for each quality domain, you can have a set of things that you monitor. Have a goal, have a target, work towards it. I've got a few examples here of monitoring metrics. For example, if you look at the right bottom one, the disposal and outcomes, I've got a deferral rate and a mortality rate and a left without completion of care rate. And each one of those gives you an indication about quality. The left without completion of care is an internationally recognized quality metric that actually is affected by quite a lot of processes. It's a reflection of flow, of throughput. It's a reflection of ambulance drop-off. It's a reflection of so many things. And you can use that, say, this is what it is, this is my target, this is what I'm going to do to get to that target and continuously improve, etc. This is what we call a run chart, and I'll chat about this a little bit later on. A run chart or process maps, we'll chat about this, but it's basically measuring something over days, over weeks, and documenting when there were changes, documenting when we implemented something, etc., etc. We measure medians and we see our change over time. Okay, so I'm going to pause there quickly. So just to recap, we spoke about governance broadly. Then we spoke about quality. Quality, I want you to know what quality is, what are the 6 domains. I want you to know what the differences are between quality control, quality assurance, continuous quality improvement. And I want you to know the basics behind them. The one is a process, the one is a system, and the one is a continuous process where there's targets and so on and so on. Let's move on to my next bit. Just watching the time, they're 20 minutes. So the next part, we're talking a little bit about improvement science. To me, this is a subject close to my heart because I think everybody wants to improve, everybody's trying to improve, but evidence shows that we waste quite a lot of money and resources if the improvement plans are not coordinated. So I'm going to give you a little bit of the theory behind it. This is my take-home message for this mini section, improvement science. Improvement is about understanding, not about implementing. I've been to so many meetings where they say, what can we do to improve? That's a complete waste of time. That implies that you know what to do or that there are certain options. Every setting is different. You have to understand what is wrong. You have to learn. Improvement is about learning and then trying to figure out what will improve. It's if you start off with, guys, what can we do? What can we do? It's usually not effective and wasteful and not sustainable. So basically, you don't need to remember the name, but to improve something, Deming is the head of improvement science, and he basically what he says, you need two things. You need subject matter knowledge. We all have that. We're emergency physicians, so we can take that away. But you also need something called profound knowledge of improvement theory. You have to understand improvement theory. And if you break down profound knowledge, there's four things that is vital. Understanding variation. How do you know you've improved? If I flip a coin 5 times and I get 3 tails and 2 heads, and I flip it another 5 times and I get only heads, does that mean I've improved my chances, or does that mean it's normal variation? Normal variation happens all the time. Sometimes I see a chart and a value goes up twice, and we've got we want to investigate why there's an increase or decrease. That is most likely just normal variation. So we'll talk about that. The second part is the human side of change, and then Kat and Candace and Martin will tell you it's all about the human side of change. You can forget everything else if you don't collaborate and incorporate and share and listen to people and get other ideas and invest into change management and understand the challenges with change. It is pointless. All your efforts is pointless. We usually see a young and confident person saying, I want to change this, and this is what I want, and this is how it should happen. It will never happen. If it happens, it will happen for a day or two, and then it will not be sustainable if you don't have buy-in. So the human side of change is probably the most important part. The third one, appreciation of a system. We can go to that one now. Systems are different. Hospitals are different. You have to have respect for the system. You can't, there's two things about this. You can't assume that something that works here will work there. You can't assume that something that works in this ward will work in a different ward. It's all because humans are involved. You have to have respect and don't enforce change. This is a very important thing. Sometimes in the past, people have gone to system. I want to go to, sorry for mentioning it, Tiger Book trauma. I want to change things now. Have respect for it. Work, try and understand what the processes are. Try and work from the inside. That's important. The second thing about appreciation of a system is wherever we are working in, we call it a complex adaptive system. The definition is you can't predict the outcome of an intervention. If it's a linear system, you can. Affected by one variable, you can kind of predict what will happen. If you, for example, take one affect change in one area, you are unable to predict what outcomes it will have because it is such a complex adaptive systems. For example, you want to change the radiology hours, or do you want to take one porter away, whatever. It was many other systems, and it's so difficult to predict. So the emphasis is on learning. Don't assume you know what will happen. It's about learning. We spoke about understanding variation. The fourth one with profound knowledge is about knowledge, building knowledge, understanding where I am. The two terms that I want you to mention in an exam with regards to this is a situational analysis or needs assessment. What do I have? How bad am I? How good am I? Where am I? What are the factors playing a role in this metric? Let me understand what's happening. Speak to the nurses. What are your challenges? You need to have knowledge about the setting before you can even attempt to change. So building knowledge. Part of this is also what are others doing? What does the evidence say? That's the part where we're building knowledge. So those are the four things that Deming says is important on top of your content knowledge. And the two needs to go together. We spoke about that. So putting all together with regards to continuous quality improvement, the best model that we are actually teaching is called the Toyota Kata, is what they've used. It's an internationally renowned model. And basically it says, say you have decided on a quality metric, whatever it is. Let's say time to triage, the time it takes for a patient to triage. Once you've done your, you've got buy-in and you've got the human side is sorted and you've got the knowledge and blah, blah, we've got all of those, and you want to start improving. This is probably the best way to do it. You need to understand what you want to achieve. So what do you want it to be? Time to triage. I'm just making an example. I want it to be as quickly as possible, and then read up and what are others doing and all that. Say the final target should be 5 minutes max. Second part is grasp the current condition. What's currently happening in my situation? Why is it happening? Do a situational assessment, do a needs analysis. What do we have? What are our resources? What are our demands? What are the challenges? Do statistics for the last while and try and understand the variation, try and understand what's happening, grasp the situation. Then the next step, you decide based on what the information that you found, decide what is a realistic target. I mean, you can't come down from an hour to 5 minutes. So say from an hour, I want to put another nurse there and I want to do this and I want to do that. Let's bring it down to 40, our target will be 45 minutes, whatever. And then you start by, you'll start by working towards the next target and so on. Finding out what are the challenges, working through it, changing something, working towards it. Once you've reached that target, go to the next one, and that's how you do it. This is probably the best way to do improvement. Get the direction, what's happening at the moment, establish the next goal, and continue experiments. And I'm not going to go into any more detail, but I want you to understand, if you look at the bottom, 3 of those steps is just planning and learning. Only the last step is executing. So basically planning and learning is the most important one. If you look at this one, understanding the direction comes from above you. What is the faculty one? What is IMSA? What is the provincial guidelines? What is the triage goal? What is the time to the consult, time to being seen? What is the goal of the province, etc.? This usually comes from above. Everything else is at your level. That's very important to understand. Very briefly, so I'm going to skip to this one. If you summarize the whole process, your current condition is where you are. Your next target condition is where you want to be. The challenge is your final goal, and then you work through the obstacles to get to your next target. That's basically the summary of improvement theory. Understand the direction, grasp what is happening in your situation, get all the information, needs analysis, situational analysis, needs assessment, blah, blah, blah. Establish the target condition and then work PDSA it through all the obstacles to get there. That's basically the summary, and I think it's important to know. Let's take a break there quickly. So let's just recap. So we've spoken about continuous quality improvement. The Toyota Kata, the 4 steps, where PDSA fits in. We've spoken about the target, the short-term target, the long-term target, etc., and how do you PSA through that. I think if you understand the processes, it's easier to implement. Let's go on to our next thing. It's 2:30. We've got a few minutes left. Variation. So how do you know what variation is? And then what is change and what is just normal variation? This is a run chart. A run chart is basically a graph where you document findings over a period of time. Weekly, daily, monthly, annually, it depends on what you want. And we look at the medians. So say the run chart, we calculate the median, and with each improvement, we calculate the next, our next level would become the new median, and so on and so on. I'll give a few examples now. The first rule of variation is what we call a shift. A shift means there are 6 values above the median of 6 values below. That means that we have a new median. That means that that is not normal variation. That's actually improvement or not improvement. That's basically what it means. So if you have a run chart and you've got a few values above the median, when you reach 6, that means you have a shift. That means you have true improvement or true worsening. It depends. And if as soon as you have that, that becomes the new median. And now you do your own thing. And once you realize that there's 6 values above, that becomes your new median. That's what we call a shift. A trend is 5 or more values that are moving either upwards or downwards. It doesn't matter if it's on the median, above or below. It's just the direction. Once you've reached that, that also means that there's been a trend and you calculate a new median. There's been a true improvement or a true deterioration of whatever you're doing, worsening of whatever. So have your median, you notice a trend, stop, recalculate your median, continue monitoring. That's how it happens. And now the number of runs is just another one. We know what is the variation and what is true improvement, etc. It's basically that there should be a number of runs determining it should cross the midline a number of times. If it doesn't, it's probably due to true improvements. I'm going to skip that one. And lastly, you guys have probably heard about value streams and process mapping. Value streams is a method that we use to try and find out where there are waste in a system. It's a method we use to try and find out whether we can streamline a system. And basically what it entails, doesn't matter what system you're looking at. If you're looking at why is the radiology process taking so long? Why is NHLS taking so long? Why is waiting? Whatever you are assessing, you go to the source where it actually happens. You take a team with you and you walk the process. For example, you become the patient. You go to the front of the hospital, you follow a patient, you see the patient speaks to the security at the gate, that's a process. Then patient is sent to the clerks, that's a process. Then the clerks send the patient back to the triage nurse, and that's how you do. So you map the whole process out. And then you sit afterwards and you analyze and you ask questions. And why can't we put this together? Can't we streamline? It's called process mapping or value streaming. That's what it looks like. This is another one. This is not a health one, but it's basically mapping out exactly what happens and then sitting back, a few people sitting and looking at it and saying, guys, why do we have the patient have to go all around? Why can't they just go in a linear fashion? Can't we put these two together? Can't we bring this part, etc.? That's what we do. Value stream map or processes. I think I'm going to stop there. Let me just go back to my. I think that's the end of it. So basically what I've done is I've taken a few, I actually have a few blitzes, a few topics that I just want to establish the concepts with you guys. And what's going to happen now, I don't know if Emily's going to introduce, we're going to have group sessions where we work around a question per group. And I want you guys to apply what was taught, apply what was in the pre-reading. Let's have a practical session, a practical approach to these concepts and feedback afterwards.
Yeah.
Do you guys want to feedback first, or should we go another group?
Everyone's back, hey? Yeah, all the consultants are back, so all the registrars should be back also. Okay, cool. Yeah, group 1, go for it.
It is, you are the clinical head of the new Klipfontein Regional Hospital and is busy designing the new EC. What systems, or describe how you will ensure quality healthcare in your EC? Charlotte, now you can go ahead.
Okay, sure. Okay, so we basically then said that from a broader picture, you've got your big systems. So that would be your bodies looking at what is expected of a healthcare facility like yours. And then taking it right from the start at looking what the population or the community is you are serving, their size and their needs. So it would be a needs analysis. And then looking at the whole system mapping. So where are the patients being picked up? How are they getting to your facility? Then your quality control within your facility-based quality control, and then integrating the patients from your facility successfully back into their community so that they can have a function back into the community. And then we were looking at how you would look at your different pillars. So the first thing we were saying is that the 6 dimensions, and that's, I can't remember them all, but it's safety, equity, effective treatment. So the right care at the right time by the right person at the right place. What is the rest, Kefas? Help me out. Quality, equity.
Yeah, so you're talking about the dimensions of quality.
Yes, so all of those 6 dimensions, and then we use the process of how we're going to make sure that all of those 6 dimensions are being met in your facility. And the tools we would use is then the 3 C's or the 4 C's, the control, quality assurance, and continuous quality improvement. And we said in helping you to use those 3 C's, you need to have a system analysis. And that's where you have to understand your situation. So it's basically you have to have your content knowledge, which we already have. We know how to manage emergency medicine patients, but you also have to have your profound knowledge. So that's looking at your humane factors and those 3 circles. And that's how you would be able to properly be knowledgeable about implementing your C's. And then what we were saying is then you'd be setting up your system. The system would be going on, and that's where you will be starting to see problems. So are we meeting the kind of measurable tools? And that's like the time to triage, the time off from the paramedics bed to your loading bay, time to antibiotics, time to RICEs, time to balloon, time to wards. So there's the measurable quality control measures that you can actually audit. And then you're going to identify where your problems are lying. And that's where you're going to use your CARTA protocol of saying, okay, our time to triage is too long. There's too many patients leaving before they're being seen. And that's where you can use your PDSA cycle. So basically coming from a macro look at what you are doing to the micro things that you have to, but none of these things can actually happen without data. You need auditing. So you need to see how many patients are we servicing? How many staff are we having? Is the staff enough for the patients? Is the staff enough for the patients? And are we managing our space effectively? And then using all of those tools. So your C's, your knowledge, your profound knowledge, your CARTA, your process mapping, your value streams, all of that in trying to encompass at the end that you're meeting your 6 pillars.
I think that's amazing. Emily asked me something just before about specifics versus structure. And I always ask the registrars in the exam, if I ask the same question to an intern and to an MO and so on, I expect different answers. And everybody will run into specifics. Structure usually gives us an indication of your knowledge and your experience and so on. So we look for the structure, and then you can fill in the blank. So that's good, very well. Can I ask you, and this is now not part of the question, but who's going to do all these things? So I'm asking, you've got the framework. How will it be? Who will implement it? Who will do it? Is it one person? Is it everybody together? I think you're muted, Charlotte.
That's where you have to create accountability frameworks. So okay. Who's accountable for what?
Yes.
So there will be the clinical aspect. There will be the, like you said, the governance is the clinical governance as well as the economic or the financial governance. And often there's the safety governance. So that would incapacitate your, your safety at the door, safety in the unit, safety around the area. Whereas there'd be the people that are actually the committee that needs to look after stock and stuff. So equipment, the labs equipment, the pharmacies equipment. So that's looking after the stuff, but there has to be separate accountability frameworks for each division, because you as the EEC consultant can't possibly manage all of those. So, and then there's the different stakeholders. So it's going to be the doctors, the nursing staff, the pharmacy, the radiology department, whether or not you've got one. And there's usually what we were saying, operational managers. So there's the clinical staff and then the admin staff.
I get you.
And yeah.
Okay. Any questions for Charlotte and Tim?
Our question was, you're in a hospital and your CEO approaches you and asks you to come up with a plan to bring down your waiting times. So we answered this as if, because we're a senior group, we answered this in a way that we thought would be structured for exam purposes. So we would start with saying that this is a broad topic and you need multifactorial inputs, and that mostly you would go to your Toyota Kata improvement projects framework. That's how you would approach the problem. The biggest and the first step would be to understand what your targets are, and then finding out what your current situation is. So with regards to what your targets are, you need to refer to whichever guidelines you are using, whether it's WHO or national guidelines, as to what is your acceptable waiting times for red, orange, yellow, green patients. From there on, you need to understand your current situation to identify the problems and where are the delays in your waiting time. And your questions, what you were asked there is where, when, and why is there delays? And this comes down to auditing and doing root analysis into the different aspects as to why there is delays in waiting time. These factors can be both internal and external. There are factors within your control, factors out of your control. So stuff like your internal factors that you can control would be staffing problems, delays in the ECG retrieval or the sonars out of a unit, stuff like that. Or external factors, so stuff like bed pressures, lab turnaround delays, X-ray delays. What is important here is to make a process map to try and understand what is affecting your waiting time and how it is delaying patients' transition through the units. So you need a structured approach to every influence that is delaying your patient's time. So if you've identified a problem, let's say that there is a delay in EMS offload of patients, you need to find a structured approach for that specific delay. So every problem you identify in your root analysis, you would need to find a specific set of solutions for. You would essentially come up with a value stream map. And then once you've identified these problems, you would do your plan, do, study, act as a collaboration with all the relevant stakeholders in your unit. So you would include nursing in finding out, well, if you had a delay in nursing and triage, you would collaborate with your nurses as to what are the delays in your triage time and find a solution going forward to it. What is important also from a big project like this, like waiting time, is to understand that it's not a quick fix, and you would feed back to your CEO that you would need multiple meetings, multiple timeframes, multiple audits to see that the processes you put in place to reduce your waiting times are being implemented correctly, and continuously do CQI based on that. I think that was basically our answer.
Okay. Any questions for? So once again, a broad question. How to improve waiting times. You can start speaking immediately about specifics, but the structure is what we want. We want to know that what are your waiting times, what should it be, why is it like this, do the value street mapping, divide it into sections, time to triage, time to this, time to disposition, for each one to process time to find out why, implement something, monitor it, feedback, blah, blah, blah. So you have to have some kind of a structure. Okay, moving on.
Clint, I think helpful for me looking at that kind of questions to anchor you. I think that input, throughput, output,
Yes.
I know it's overcrowding. It's the overcrowding kind of way of thinking, but for me, that's quite useful to use in any of those kind of things. It's input, throughput, output.
100%. So we have discussed it, the terms. It's actually perfect. So output, anything to do with the hospital, access block, boarding, crowding, it affects your waiting times. Input, you can go as far as saying, should all these patients actually come here? Shouldn't they go somewhere else? Blah, blah, blah. And throughput is what's happening in your unit and all that. So very good. I agree with you. You can also think of it logistically, how to improve waiting times. You do less or you have more staff to do it. That's the two big groups. You can think about waste. What can we take out or can we get more? But that's an oversimplification. There's many ways of looking at it. But some structure and mentioning a lot of specifics won't install confidence with examiners and whatever. It won't instill any confidence. It would be just a rambling of specifics. So I'm looking for a structure. Good.
I think Clint, what they were also telling us is showing them a little bit of your understanding of why we do certain things. For instance, mentioning things like the nurse-driven inputs, or why something like a Canadian C-spine rule or in the Nexus rule is useful, because those things can all influence waiting times. Someone lying on a stretcher, if you apply the Nexus rules, they can be cleared and they can sit on a chair. And it's maybe just a little bit even on top of all those kind of basic systems to show that you've got some insight into other standard practices of care.
Yes. So where I would fit that into is the waiting times, time to triage, time to consultation, time to disposition, time to exit, and ambulance drop-off time is the other one. Within time to disposition, once you've done your walkabout or your value stream map, you will find out all the aspects that affect time to disposition. Lab turnaround, radiology turnaround, port availability, nursing orders, blah, 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 blah. Then for each one of those, you try and find out why, and that's where that fits in. So you have to bring it back to your structure, if you know what I mean. So you would say, NHLS, are we ordering too much? Are we ordering unnecessary? Is it a problem with getting the sample to the lab? Is it a problem with lab turnaround? What is the service level agreement? There's so many things, but if you bring it to the structure, it's easier. It's a little bit better. Right, team number 3.
So I think it's our team to go. We were.
Hey, how are you?
Team Martin and Camlin. Hello. We were discussing issues around patient safety incidents. So we started off trying to define what it is, and simply put, it's like having an occurrence or event that happened throughout the patient's journey in the EC, which resulted in unnecessary harm, basically. So we went on to say, how do you actually categorize it? Because it can be perceived in a hierarchical way. So the first point is whether the incident had no particular harm to the patient. An example would be a patient with an altered level of consciousness, perhaps maybe, let's say, a psychotic patient that was in a bed with the rails up, but somebody left it down and the patient walked about. So it didn't really cause a harm to the patient, but it is considered as an incident. In the same instance, with the second hierarchy, the incident may have occurred, but there wasn't any adverse complication in that incident. So that they gave a patient sedation or a wrong type of a medication that could have complicated from that, but didn't. and an adverse event with complications with regards to being given a wrong administration of medication. So basically coming from an incidence of no harm where the rail was off to being given medication where something worse could have happened, but it actually didn't, and then to actually complicating from that. So we went to then say, if you have an occurrence where an incident is reported, what would be the challenges that you can encounter in this? And I think it was just about an approach of knowing that the first thing that needs to happen is you need to recognize that there was an incident to begin with, and have processes that are available where you can report these incidences. But bear in mind that there could also be fear of victimization in the process, which could really impair how many people come forth to report incidences. And if there isn't a culture of feedback that is given, the utility of the process becomes unappreciated by those that should be involved in the system. So we highlighted specifically with regards to victimization, what could you do when addressing staff regards to this? And I think the important thing is when you are giving feedback or involved in the process, to remove blame on a person, victimizing a person, but try rather to identify the system factors that have resulted in that incident occurring in the first place. So that's one thing. And another challenge with regards to staff reporting would be perceived hierarchy, to say if you are in a position of a consultant, that you are less likely to have made mistakes, and therefore when you're junior, you most likely will be. And I think that also causes some kind of a chasm, a difficulty in expression when it comes to reporting. But from a senior position as a consultant, take the responsibility to say that, voice out your vulnerability as well, that you are a person that could also make mistakes, and following through the process of reporting is also quite important to you in your position as well, in your leadership position. And then we said, so now what's important is to recognize the systems that you can put in place to facilitate the process to actually occur. And like you say, verbalizing the need to recognize what incidences could occur, whether it's in a form of expressing it in a huddle in your EC or not. Identifying a PSI officer, when somebody knows that in a case of needing to report, this is a person who's accountable for it. But the process of making it easy, the communication part, could be formally writing written documents, or you can facilitate it and make it even better to make it digital, so that access to the process is also quite easy to follow. And most importantly, have a way where there is accountability for that officer to give feedback, so that the culture of reporting is reinforced in the system. So I suppose that's in a gist what more we discussed.
That's amazing. So I haven't touched on this in my talk. I left out quite a bit, but basically patient safety and risk management, you guys need to know what it is, what it entails. You need to know the definition of a patient safety incident, what she mentioned initially. You need to mention the three types, the no harm, near miss, and the harm. You need to understand the value of reporting and the challenges associated with reporting, the just culture, openness, and all those things. You also need to understand the processes. So you need to, once you report something, you need to investigate it. So you need to find out, okay, something bad happened. Why did it happen? So you can also do the root cause analysis thing here. The nurse gave 100 milligram per mole ketamine instead of 10 milligram per kilogram, whatever ketamine. So why did it happen? So you can do an investigation. So it was busy, it was crowded, one nurse in the whole unit, blah, 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 blah. Long story short, the ampules look the same, and it's stored in the same cupboard, blah, 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 all those things. It's easily, there wasn't a system to double check it with another doctor to say, or another nurse saying, read it out loud. So you try and understand why, root cause analysis, 5 whys, or a fishbone or whatever, and then you try and implement something so that it doesn't happen again. And this, like Martin would have told you, also needs a system. So you need to kind of discuss this amongst everyone and then implement something and monitor that it is happening. For example, let's store it in different cupboards. Let's put a red sticker around all the 100 milligrams per ml so that we can identify it. As soon as the nurses open the pack, put the red stickers, blah, blah, blah. Let's educate, let's this, blah, 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 all those type of things. So it needs to, so this is also where the root cause analysis and CQI also comes in here technically. If you guys think about it, you want to improve something that you identified from the risk, all those. You have an M&M, you identify a problem, root cause analysis, find out the problems, implement something, feedback, monitor, make sure that it doesn't happen again, etc., etc. Kamlan, you wanted to ask?
Yeah, hi Clint. I just wanted to ask you something so that I don't get myself in trouble in an exam. So say, for instance, so I know the root cause analysis and these things are buzzwords, but there are criticisms of the root cause analysis technique, particularly in assuming that there is one single root cause, in which case it's not typically the case. Is it okay if you don't say such things, but you describe an entire process where you do a fact-finding mission, you investigate, you look for local factors, local knowledge, global knowledge, factors that occurred at the time, contextual factors in terms of investigating an incident, which is not particularly as rigid a structure as a root cause analysis, particularly because in the case that you described now, maybe the ketamine vials, you might stop at saying, oh, the ketamine vials look the same, that is my root cause, I'm done there. In which case, you know, then you've neglected the other issues. So in an exam, do you have to mention things like a root cause analysis? Or is it okay to say, look, it's reasonable to perform a root cause analysis, but assuming that it may not be a single cause and therefore we take a different approach to it?
So Kamran, very good. There is never a single cause, and a root cause analysis doesn't imply that there is a single cause. It just describes the process. I would advise you guys to use the fishbone approach. The fishbone approach has different sections, systems, equipment, personnel, whatever. That kind of encompasses everything. And for each one, you have subheadings. So with regards to the vial thing, for example, a fishbone approach of the root cause analysis would be, from a systems point of view, there was no checking of the double checking before the drug was given. It was kept in the same thing, blah, blah, blah. From a personnel, people are tired, overcrowded, blah, 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 one nurse. So it's never one cause. So root cause analysis means all the causes, it's the process. There's different ways to get to the bottom of it. You can have the 5 whys, and the 5 whys also takes you to a lot of possibilities. But my suggestion would be the fishbone, because it's comprehensive, like you said. So I would say I would perform a thorough root cause analysis. I would use the fishbone approach, and I would investigate each limb, systems, personnel, equipment, staff, environment, whatever. And for each one, there's subheadings, and then your implementation, your change would probably be on multiple levels at the same time. So do you understand what I'm saying? So well done. I agree with you 100%. So this was part of my talk. I skipped that part. I will share everything with Lauren. What Charlotte spoke about, the summary of the patient safety stuff. We've got all of that. I can share it, and you guys can go through it. It's on slides and all those things. We can do it afterwards. All right. Well done. And team 4. The Legos. Oh, what is that?
Okay, so team 4 is our team.
Hello,
hi, Clint. Hello, everybody. Yay. So we had a scenario where a confident third-year registrar saw a patient, a 20-year-old, and missed a posterior shoulder dislocation on X-ray. And the patient was discharged and came back 6 months later with essentially a destroyed shoulder. And the question was, how would you manage the situation?
Who's that? So, sorry, it's fine. Continue.
Not me. So we decided to say, we spoke about dealing with the patient in front of you and then dealing with the bigger picture. So when dealing with the patient in front of you, it's important to offer an apology, an explanation, and then a remedy. So it's important to be honest and upfront with the patient, to show empathy and support. and to make the patient feel like you're addressing their problem. It's also important to meet the patient's new health needs. So you should be prepared in these kind of cases where essentially the system has failed the patient to go above and beyond, try and fast track the patient to specialist referrals, physios, make sure that the patient actually has an appropriate plan. And then we spoke a little bit about the fact that a hospital will have a patient liaison officer or a complaints liaison officer who is very well equipped in the soft kind of skills in terms of dealing with these kind of complaints, and that you should involve that person early, as they are probably a better medium to go through for the patient. And there's also a lot of support to be given by medical legal departments, both in the hospital and at the Department of Health. So that's just dealing with the patient in front of you, making sure that the patient's needs are addressed, making a plan for the patient, and telling the patient that you see that there's a problem, you're going to investigate, and you'll follow up with them. In terms of actually investigating the bigger problem, we broke it down to getting information. So gathering all the available information, then doing root cause analysis and identifying the specific problems, and then later addressing each problem. So for getting the information, you would speak to the patient, find out exactly what happened at the time. You would speak to the doctor, get their side of the story. You'd look at the notes, the x-rays. You can also look at the stats for the unit for that day to find out whether it was busy or not. You can look at what time of the day it was, the date, was it the end of month, weekend nights when there were 500 stabs and 3 frontal thoracotomies. And then you look at what happened between that time and now. Was the patient supposed to follow up but didn't go? Did the patient actually come back to the unit 5 times but was turned away at the door? So what happened between that time and now? Were there other opportunities that have been missed to address the situation? And to look at what's happening now. Why did the patient present now? Were they referred by a private GP? Were they referred by lawyers? Did they come with their full legal team behind them? And once you have all the information, we move on to doing a root cause analysis. So we spoke about different ways of approaching root cause analysis. So there's random brainstorming, which we started with, and then we got nudged in the right direction. So the 5 whys theory is good for identifying the root cause, but it does tend, like Carmen said, to push you down one track. So we ended up going with more of a fishbone kind of approach. So we looked at people aspect. Was there a staffing shortage? Was the doctor burnt out because he's been working a million night shifts? Is there a specific knowledge issue with the doctor, so that you'd go to the doctor and ask them, why did you, did you look at the x-ray? What was the issue? Did you not see it? Do you not know about posterior dislocations? Did you examine the patient? All of that, those things. Looking at processes, it would be about, was there an appropriate safety net for the patient? So after discharge, did you tell the patient to follow up? Should that be incorporated as a process routinely? Is there a follow-up policy at the hospital for patients coming back with queries, or do they get thrown away at the door because they're green patients and must go to the CHC? When looking at equipment, we obviously spoke about x-ray quality. Was the x-ray machine working? Do you have x-rays at that time of night? Are they proper quality views? When the doctor's viewing the x-ray, was there a board that's working? Was it film x-rays? Is there a computer that's working? Can the doctor log in? Those kind of things. When we spoke about environment, it was a lot of discussion about unit load. So patient load in the unit, was the unit overflowing? Were there 500 stab chests? Also about the time of day, the date, and things like, we're in the middle of COVID. They've got a lot of other things going on besides looking at people's shoulders. In terms of management aspect, we look at the availability or the approachability of seniors or consultants to ask questions. So if you see an x-ray and you're unsure, should they have phoned someone and asked an opinion? Are the consultants approachable? Is there an issue with communication between the higher structures, your inline manager and yourself? And similarly with orthopedics, is the relationship between the EC and orthopedics good enough that you can quickly phone the orthopod and ask them to take a look at the x-ray? Is that appropriate to do an ad hoc referral like that? But those are all management kind of issues. And then we didn't think that materials were specifically relevant for this case. So once you've identified then all of these specific issues, you then move on to your PDSA, evaluating each issue individually, planning, setting a goal, brainstorming ideas, implementing, measuring, and feeding back.
That's amazing. How would you manage the doctor after he made a mistake?
So I think it's very difficult. I think having been one of those doctors before,
we all have been.
Yeah. So I think that it's important to identify what the root cause is. Is the issue a knowledge gap? Is the issue an overconfidence issue? Is it an overworking issue? Depending on what the actual root cause of the doctor's error is, the management would be different. I think my style of addressing it would to try very hard not to be putting blame on the doctor, trying to actually identify what the root cause is and addressing that.
Cool. What's the time? It's 4 o'clock on the dot. Where is Emily and there's Lauren? Guys, thank you. I just want to quickly summarize. So, as I said in the beginning, there's no way you can do management in an hour or hour and a half. I literally took out a few topics and just run with it, and then we tried to apply it in a few cases. I'm going to send a few resources now after to Lauren. Lauren can distribute it, but basically know what clinical governance is, know about the pillars, corporate governance, know about it. Don't need to go details about that. Know what quality is, what the 3 different types of quality stories are. Know how the CQI processes work, because you implement it everywhere. It's not about PDSA. PDSA is the last step. It's about all those other things. Know about variation. They've never asked about variation, but it's something that's important to understand. Know how to do a root cause analysis. Know about process maps and value streams. And yeah, so I'm going to, and then patient safety. Know about the definition, know about the 3 things, the process, why we do it, etc. So we actually covered quite a lot. I will try and put it together and send it to you guys. I think that will cover a lot of the possible topics. And remember, every question probably has a management part to it. Every question. We expect you guys to answer from a consultant level. Remember, the exams is for a consultant, not for a registrar. We expect you to answer from a consultant level, and you guys all have the knowledge. This is just to help you structure it. That's the summary from my side.